Continuing with the screening test and the EPT and PT and PT, if EPT is prolonged, 50 or 50 minutes with normal plasma intestinal footing possible by proficiency of pregnancy and update traveling time test for deficiency or dysfunction of inflammation contemplated for the major assay leading us to test for carbon depletion products biochemical screen including rare and functional. So lead time is no longer used to investigate greater disorders unless it is unreliable. Test glucose which as separate functions. And in the neonate, the levels of hormone fatigues factor 8 infiltration are lower. Preterm infants have even lower levels. Therefore, the results have to be temporarily normalized in similar gestation post-natal age. In view of this, because it is often difficult to obtain good quality immunity samples, it is often necessary to exclude an entirety population factor and exceptional type of performance and analysis both on a child appearance. Hemophilia, the most common severe inherited population disorders, are hemophilia A and hemophilia B, both have X-rays as inherited hemophilia A, there is at A deficiency, it has frequency of more than 5,000 male births. Hemophilia B, 59 has a frequency of more than 30,000 male births. 2/3 of newly diagnosed infants in our family history of hemophilia, whereas 1/3 are sporadic. Identify female carriers requires a detailed family history analysis of population factors and DNA analysis. Prenatal diagnosis available using DNA analysis. This is the normal and hemophilia A and then one brand. One Wilbur factor carrier protein protects F1815C from degradation released and activated from it. Defective synthesis or HCC and one Wilbur. The degradation of factor 8C in the absence of one Wilbur factor. And creative hemophilia, these are the severities. And if factor is less than 1%, it is severe. Spontaneous joint velocities, it's severe atrophy from the time leads hemophilia. We have not managed to prevent it from 1 to 5 has moderate bleed after myeloma, and it's factor 8 is what you call it, 5 to 40% mild bleed after surgery. So this is clinically treated as severe, moderate, or mild, depending on factor 8 or 9 hemophilia B level. The form of a severe disease is recurrent spontaneous bleeding into joints and muscle, which can lead to crippling arthritis if not properly treated. Many of these children have large perceived control pressure, such as being picked up or knocked at a portrait, knocking portrait, or in those with no family history, this may lead to a suspicion of non-accidental injury. Toward the end of the first year of life, when they start to crawl and fall over, children begin to develop muscle and joint bleeds. Almost 40% of cases present in a neonatal period, but appear large capillomatomas and intracranial hemorrhage leading to circumcision or prolonged from heel stick and interpunctual sites. The severity usually remains constant within a family. Maximum prophylactic rate in 9 given IV is considered to be the standard of care in all children with severe hemophilia and B respectively to reduce the risk of chronic joint pain. The goal is to maintain a factor concentration of at least 1% to 0.4. These primary prophylaxis usually begins around 1 year and is given every 2 to 3 days if peripheral venous access is poor, central venous access device with the gap may be required. Prophylaxis has been shown to result in better joint functions and adult life. Parents are usually taught to give replacement therapy at home, and many children are able to administer their own treatment from 7 years to 8 years. During acute bleeding episodes, recombinant effective concentrate is given by form intravenous infusions. Recombinant products are available, highly purified, widely inactivated plasma-derived products should be used. The quantity required depends on the size and nature of the bleed. In general, raising the circulating levels 30% of normal is sufficient to treat minor bleeds and simple joint bleeds. Major surgery life-threatening bleeds require the level to be raised to 100%, and then maintained at 30 to 50% for up to 2 weeks to prevent secondary hemorrhage. This can only be achieved by regular infusion of factor concentrate, usually 8 to 12 hourly for factor 8 and 12 to 24 hourly for factor 9 over continuous infusion or by close monitoring plasma levels, intramuscular injection, aspirin, and non-steroidal analysis should be worked on patient and failure and contraindicated complications are listed. And these are inhibitors antibodies to factor 8A develop in 30% patient hemophilia A, but only 3% patient hemophilia B reduced to completely inhibited the effect of treatment, usually treated with immune tolerance reduction, which involves regular exposure to large quantities of factors even for long-term transfusion, transport infections, and various EBC, HIV, other prions, and protovirus B19, vascular access, peripheral veins, no difficulty to cannulate, central venous access devices may become affected with thrombose. Desmotylated AVP stimulates release of endorphins factor 8, however, when may allow mild hemophilia A to be managed without the use of drug products. It is given by infusion. Adequate levels can be achieved to enable minor surgery and mental extraction to be undertaken. DDAVP is ineffective and hemophilia designated hemophilia centers normalize, authorize, normally supervise management children with being disordered with mental discipline approach by expert medical nursing the not input. Specialized physiotherapy is needed to preserve muscle strength and avoid damage from immobilization. Psychosocial support is an integral part of maintaining compliance. Patient support organizations such as Hemophilia Society may provide remedies with helpful information and advocacy. One with red disease is a large glycoprotein produced in the vascular medium has two major root of visitors, pathetic adhesion, platelet adhesion to damage relatively metastasis between factor 8, protecting it from inactivating adherence. Polymer results were either quantitative, qualitative deficiency of polymer factor. This causes defective pigment by formation signal in dense carrier protein factor 8, which shows non also have effective deficient in factor 8. There are many different mutations in a non-pigment infected gene, resulting in many different types of non-pigment factor. The inheritance is usually autosomal dominant. The most common subtype type 1, 6 to 80% usually fairly mild is often not diagnosed until puberty or adult. Clinical features are bruising, excessive prolonged bleeding, upsurge, and impulsive bleeding, such as epilepsy and menorrhagia. In contrast to hemophilia, spontaneous soft tissue bleed in such as large hematomas and phosphorus are uncommon. Treatment depends on the type of sedative disorder. Type 1 can easily be due to DAP, causes secretion of both vector and electric plasma. DAP should be used with partial children less than 1 esophagus when for capital treatment due to water retention and may cause seizures, particularly if repeated dosing and fluid intake is not strictly regulated. More severe types of 1-year disease have to be treated with plasma gel factor 8 concentrate or as they will be ineffective and the dominant factor 8 concentrate is no one will be affected. The common 1 milligram factor has a number of clinical trials may soon be licensed for use in adult patients. IM injections has been an associated with avoiding all patients, same as with the acquired disorders of coagulation. The main acquired disorders of coagulation affecting childhood are those with deficiency causing ultimately deficient bleeding, hemorrhagic disease or newborn, and that we discussed very notably, I guess. Liver disease, immuno ITP, and disseminated coagulation. Vitamin K essentially production of active forms of 2, 7, 9, 10, and the production of naturally occurring anticoagulants such as protein CNS. Vitamin K deficiency therefore causes reduced levels of these factors. The main critical consequence of this is prolonged maternal time and increased risk of bleeding. Children may become deficient in vitamin K due to inadequate neonates, not of chronic illness with poor intake, malabsorption, celiac disease, cystic fibrosis, obstructive jaundice, vitamin K antagonist, warfarin, thrombocytopenia as a platelet count less than 150. The risk of bleeding depends on the level of platelet count. Severe thrombocytopenia platelet less than 20. Risk of spontaneous bleeding, moderate thrombocytopenia, placed 30 to 50 at risk of excess bleeding during operations at all, but low risk for spontaneous bleeding, mild thrombocytopenia, bleeding 50 to 150, low risk of bleeding unless there is a major push of storage. Thrombocytopenia result in bleeding, petechiae corpora, mucosal bleeding, epistaxis bleeding from gums when patient is major hemorrhage in the forms of severe GI hemorrhage, hematuria, and Dropping these is much less common because of easy using purpura listed, while purpura may signify thrombocytopenia that occurs with a normal platelet count from platelet dysfunction as well. Specifically, thrombocytopenia is the most common cause of thrombocytopenia in childhood. It has an incidence of around 4 per 100,000 children. By the way, it is usually caused by structures of platelet platelets by antiplatelet IgG or antibodies. So reduced plasma count, platelet count may be accompanied by a compensatory increase on lifetime in bone marrow. Clinically, most children present between the ages of 2 and 10 years with onset of 1 to 2 weeks after viral infection vaccination. In the majority of children, there is a short history of these disease. Affected children develop peculiar programs superficial bruising. ITP can also cause sex and other because of bleeding, but diffuse bleeding is uncommon despite the fact that platelet count performs less than 10, and intracranial bleeding is a serious but rare complication, including 0.1 to 0.5% mainly in those with a long period of severe thrombocytopenia. In about 80% of children with disease acute, benign, self-limiting, usually remitting spontaneously within 6 to 8 weeks. The following definition is used in FP based on duration. Newly diagnosed ITP duration of less than equal to 3 months, persistent ITP 3 to 6 months, chronic ITP duration more than 6 months. Treatment recommendation vary according to the duration of ITP. ITP is a diagnosis of exclusion, so careful attention must be paid to the clinical features and blood film to show that more serious disorders such as hepatitis, thrombocytopenia, A+, and leukemias are not missed. In the younger child, a congenital cause such as the spot embryo or Bernard-Sweeney syndrome should be considered. Any atypical clinical features such as the presence of anemia, neutropenia, hepatitis, and getting marked lymphadenopathy should prompt a bone marrow examination to exclude leukemia and possibility. However, most children with unserious thrombocytopenia and non-life-threatening mucosal bleeding treatments can be given without prior bone marrow examination. Systemic leukocytosis should also be considered in adolescents. And these are the cause of purpura or easy bruising, and these are the case histories. The management will do this. Let's finish the thing first. And management, most children can be managed at home and do not require hospitalization. Treatment is controversial, and most children do not need any therapy in their platelet count system. But treatment should be given if there is evidence of major bleeding, intracranial GI hemorrhage, or persistent minor bleeding that affects daily life, such as excessive or excessive menstrual bleeding. The treatment options include oral prednisolone, IV immunoglobulin. Both have significant side effects. Platelet transfusion are reserved for life-threatening hemorrhage as a reason platelet count only for a few hours. The parents need immediate 24-hour access to local treatment, and the child should avoid trauma as far as possible in contact those where the platelet counts vary. Chronic IDP because 30% of which affected individuals. In the majority treatment, this means supported drug is only for children with chronic persistent bleeding that affects daily activities or impairs quality of life. Children with significant beta require specialist care. Variety of treatment modalities are available, including thrombopoietin receptor agonists, TPORA, such as Eltrom, available as early orally, and Bromine, weekly subcu injections are given in toxin have immunized monoclonal antibodies directed against B cells can also be given as a secondary treatment if TPO is not available. Spinectomy can be effective for this drug, but it's mainly reserved for children who fail drug therapy as it significantly increases risk of infections and patients require lifelong antibiotic prophylaxis. If ITP in a child becomes chronic, regular screening for SLE should be performed as the thrombocytopenia may predate the development of autoantibodies. DIC describes disorder characterized by coagulation pathways activation leading to diffuse fragment degradation in the muscle microorganisms and also coagulation factors and platelets. And the most common cause of activation of coagulation are severe substrate strong due to circulating collapse and meningococcus septicemia, extensive tissue damage and traumas and burns. DSA will be acute to chronic and is likely to be initiated through the tissue factor pathway. They are predominant clinical features bruising, purpura, and hemorrhage, and however, the critical process is characterized by microvascular thrombus and purpura. Convulsions may occur. No single test reliable diagnosis. DIC, however, DIC should be suspected to prevent abnormal people. It's a thrombocytopenia, long EPTT, low fibrinogen, Based on the decomposition part of the diagnosed and microbial anemia, there is also usually marked reduction in the measure of the guidelines between C and BTS, and I think probably the most important aspect of management is to treat the underlying cause of CSC. Researching by providing intensive care, supportive care may be provided with a fees to the case conduct that described as again previously and it remains controversial. Some positions, this is unconventional and about 95% of venous thromboembolic significantly underlying disorders associated with hypertrophic states such as severe substance dehydration, disseminated DIC, is often exacerbated by running cerebral catheters. The bruises of cerebral vessels usually present with signs of strokes. In addition, there's really should remain inherited abnormalities and population for the pathway increase the risk of development cause even in the absence of underlying predisposing factors. These conditions are termed congenital prothrombic disorders, thrombophilia, there's protein C insufficiency, any combination C defective laden, and prothrombin gene G 2021 E mutation. CNS antithrombins are natural thrombins, and the deficiency inherited in an autosomal dominant manner. Heterozygous also predisposes to thrombosis, usually venous, during the second or third decade of life, non-linearity in children. Homozygous deficiency of CNS are very uncommon, present life-change thrombosis with widespread hemorrhage purpura in the skin, known as purpura fulminans. In the neonatal period, homozygous antithrombin deficiency is not seen probably because it is lethal in the fetus. Factor V laden is inherited and the the structure of the transmission protein factor 5, which makes it resistant to degradation by activated protein. C is part of the body's normal integral mechanism. The prothrombin gene mutation is associated with high levels of plasma thrombin. These are subclinical required causes of thrombosis are catheter-related DIC, hypertension, polycythemia due to congenital heart disease, malignancy, SLE, and persistent antiphospholipid diagnosis. Although inherited thrombophilia is very uncommon, these disorders predispose to life-saving thrombosis. It is important to not miss the diagnosis. Any children presenting an unexplained thrombotic event, therefore screening tests for the presence of inherited thrombophilia should be carried out in the following situation. Any child with unanticipated or extensive venous thrombosis, ischemic lesions or neonatal purpura fulminans. Any child with a positive family of neonatal purpura fulminans, screen tests are assessed for CNS, antithrombin SM polymerase reaction for factor V laden and for the prothrombin gene mutation. Mutations factor V laden, and the prothrombin gene respectively are present in 5 and 2% of the Northern European populations. Children with protein C deficiency or factor V laden have 4 times to 6 times higher risk of developing recurrent thrombosis. The risk increases significantly if these conditions are inherited together. Therefore, it is reasonable to screen children who develop thrombosis for all of these factors in order to plan the best management to prevent thrombosis in UK. Current practice not to screen asymptomatic children for genetic defects that are not going to affect their medical management on the basis of family history alone until they are old enough to receive appropriate counseling and make decisions for themselves. Summary: all children with thrombosis should be screened for nitrogen and acquired predisposing factors. This child is petechia, non-thrombocytopenic, phenolphthalein, lesions confined to buttocks, sensor surface of legs, and swollen painful knees with ankles, abdominal pain, hematuria, sepsis, has meningococcal or viral clinical features, fever, septicemia, meningitis, rash, and meningococcal sepsis, positive class test. If suspected, give parental penicillin immediately. And trauma, accidental, non-accidental causes are rare, and these are thrombocytopenic LTP 2 to 10 years, vitrectomy, purpura, and superficial bruising. Distinguished from acute leukemia, plastic anemia can be featured foot with count and blood film. Bone marrow examination not required if only the platelet count is low. Infectious clinical features is acute benign self-limiting in about 80%. Treatment contribution usually not required unless there is a major persistent bleeding. Leukemia clinical feature: malaise, infection, pallor, hepatosplenomegaly, lymphadenopathy, blood count also low HP, blast on film confirmed on bone marrow. DIC is critically ill, severe sepsis, shock, or extensive